Sam, another great Rowe educational event with our staff today. Today the topic was Pontic design. That's actually a subject that I wanted to have discussed because I think there's a lot of ambiguity surrounding Pontic design that I think hopefully you cleared up today. So Sam, what are the main Pontic designs that we create here for doctors and patients at the lab?
I'd say the most common one in our standard is the modified ridge lap. Although we do take into consideration the shape of the tissue, we take into consideration other factors in maintaining a hygienic design. So it's either a bullet shaped or a modified ridge lap or some type of ovate style Pontic that really looks correct coming out of the tissue.
So if a doctor doesn't request otherwise, we provide a modified ridge lap if the tissue shape allows.
Yeah, the tissue shape is going to dictate that. But as a standard, it would be if a doctor didn't dictate that, it would probably be a modified ridge lap, just for aesthetic purposes most of the time. Yeah.
So on our prescriptions that the doctor sends over, what are the most common Pontic design the doctor requests?
Well, I mean, to be honest with you, BJ, the most common thing is none. We get no information. That's really one of the things that we look for as a technician. We want the information from the doctor, but oftentimes there's a section on the prescription that says which Pontic type would you like, but I'd say the majority of the time it's not checked and that information is not given to us. So we want that. We want that information. The more data you can give us, the better we can give you the product that you want. But lots of times we just make that decision based on the information that's given to us, the model or the digital scan or the tissue design.
Okay. Now, a lot of times we receive the Pontic sites are a little rough. There's this recent surgery, recent extraction. When we look at the tissue, it's irregular. Our job as a lab is to try to make something hygienic that's going to last the patient's lifetime. What do we do when we find a tissue shape is rough, and the tissue site is rough, and what can a doctor do to improve the results on a recent extraction case?
Well, I mean, as a standard here at the lab, we would have to take a little, football-shaped burr and maybe smooth that area out. We never want to create a Pontic on a site that is bumpy or has waves. So we're going to use that information to, contour it. And that's something that a skilled technician here really oversees and does. You have to kind of know how much to take away, how much, and even if we're making a soft tissue, we often take a burr and smooth that soft tissue or create the right site. And especially on implant cases too, because lots of times the doctor asks us, to improve the implant site. The implant is just a circle. We want to improve that implant site, but we never know how much to improve it, how much to reduce. And so we use a judgment call. We use, and sometimes doctors want us to be more aggressive than others, but once again, that's data, that's information that we need. We want you to tell us, hey, reduce 2 millimeters from the mesial, reduce lingual, give me that right shape so that it'll look like a tooth emerging from the tissue. So it's a judgment call really made by more of a senior technician on how much to reduce and where. I
know oftentimes we get on the prescription ovate Pontic, where the doctor hasn't created an ovate site. We typically interpret that as a bullet-shaped Pontic, more of a sanitary Pontic that's just touching the ridge. But if a doctor actually wants us to do place a surgical incision and create a Pontic site at the time of placing the final restoration, which obviously isn't ideal. They should do that at the provisional stage. How would our client articulate that on a prescription to indicate he wanted to kind of surgically, create a site for a Pontic?
Yeah, that's always like such a tricky debate. Okay, and we do see that from time to time, and it's really just understanding, how much you can reduce. I don't want to go in there and dig a giant hole to create this bullet-shaped Pontic without knowing that the doctor's okay with us going that deep. So once again, it's going to be really a judgment call of a senior technician or a manager to determine either based off a doctor's preferences or how deep he wants us to go.
Having a food trap on a bridge is a challenge, or an anterior restoration. What are some of the things that our client can do on their end to help make sure that the restorations don't have places where food can impinge and food traps?
Yeah, we see this all the time, where we have to make the determining factor on the choice of the Pontic. And the one thing that a doctor can do for us is, once again, is data, is information. We need the doctor to maybe contour the tissue site so that it's there in the impression, so we don't have to do it. Doing those things chairside with the temporary, giving us information, more data is always more beneficial. Take that judgment call out of our hands.
Okay.
Tell us what you want on the prescription. Show us how you want it on the tissue, on the model with your temporary, or even in an implant situation, take the time to put in a custom healing abutment to contour that tissue, or and show us exactly what you're looking for. So once again, it's something we lack here often from the doctors, is data, is information. Tell us, take the time to fill out the whole prescription and tell us what you want. So it's data.
So one challenge I see a lot in our technical services area, Sam, is in the bicuspid region with Pontics, when the bone would dictate more of a ovate or a bullet-shaped Pontic, something that's more hygienic. Yet, if we see a picture of the patient and see their smile line and see the profile of the adjacent partner teeth, we can see that really we need to build out that buckle to improve the aesthetics. What would you suggest to our clients in those situations when we have to decide between the two? Because a lot of times we don't get the information to make that decision from them.
Yeah, it's definitely a common issue that comes up. We have to decide if we're going to do a hygienic design and so the patient can clean easy, or we're going to do an aesthetic design that's in the aesthetic zone. And it's always a question that comes up on anterior cases, and more often than not, it is a doctor preference. It's understanding the clients and understanding the doctor. Tell us in your preferences when you start working with us, hey, I really like to lean towards the aesthetic option. My patients want these modified ridge laps. They want ridge laps. They don't want to see, the cervical margins are uneven. They want to keep it in line. So knowing the doctor, letting us know that we can contact you, that we can ask you for advice on how you want a case done, it really goes a long way.
It's a challenge because we do the same case for two different doctors. In one case it's great, and one doctor says it's great, and one doctor says it's wrong. It's just different preferences, different practice philosophies, different patients, right? What the patient's opinions are.
Yeah, absolutely. And sometimes as professionals, we know better. Like, I would want a really hygienic design. I would want to make sure my tissue stays healthy and clean.
Right.
And but some patients, they compromise that with aesthetics. We want to design a Ponic site that remains aesthetic to the patient. And maybe it's not always the most hygienic or easy to clean, but they're happy.
Photos always help, right?
Oh,
if you have a photo, we can kind of tell what we need to do.
Photos are huge. That's huge. But a photo doesn't tell us still what the Ponic design you want.
Sure.
So information again is key.
Awesome. Well, you did a great job today, Sam. Thank you for doing the presentation. Look forward to next week's presentation.
Awesome. Thank you.
To receive a copy of the Pontic Design Principles lecture, visit www.rowdentallab.com/rowreviews.